I'd like to thank everyone for the opportunity to address this audience about kidney transplantation. I will try to, as a surgeon, we like to keep things simple. That's what our medicine colleagues often make fun of us about, but why not? So I will only give you 5 slides because I want you to take home 5 points about kidney transplantation, and keep it as simple as possible, and then answer questions. So, number 1, transplant is the best treatment option for kidney failure. We want to convince you guys of that today. If you're an appropriate candidate, this is the best modality to treat your kidney failure. As Dr. Gilbert pointed out, there are many aspects of quality of life that are better with the transplant compared to dialysis. You free up time, dietary restrictions, a better energy level, ability to travel, and numerous other things that are better with a transplant compared to dialysis. Longevity, there were some very nice graphs in the prior presentation about any age range, how much more life extension there is with transplant on average compared to dialysis. The unfortunate thing is, kidney disease as a whole robs people of years of life. Dialysis keeps you going day to day, week to week, and month to month, but if you compare a transplant to dialysis on average, in appropriate candidates, people with a transplant will live much longer than their same age people on dialysis. But it's important to point out that this is not a cure. I wish this was like when I take out someone's gallbladder or their appendix. You take out their gallbladder, their incision heals up, you see them in the office, and their gallbladder will never bother them again. Unfortunately, with a transplant, you do the operation, they heal up, and as I like to say to the patient, now the work has begun. And for a while, the work does start. New medications, learning new things to be aware of, infections and other things that you have to keep track of, and sort of things to watch for because of the immunosuppression medications, and also labs and doctor's visits. But when you compare that to going to dialysis or doing nightly peritoneal dialysis, over time, all of that stuff becomes much simpler and much more sort of ingrained, and also spread out in terms of how often you got to go see your physicians or how often you have to get labs, that all of that becomes much simpler for you compared to dialysis. Number 2, get referred early. There are a few changes that are happening that make this perhaps less important for some individuals, but it's still important to get referred early. Once your GFR is 20 or less, you can be listed, assuming that you qualify from another medical perspective. A workup is almost always needed once you're on the list or to be placed on the list. And a lot of these things are routine health care that even if you didn't have kidney failure and didn't need to go on a kidney waiting list, these are things that when we see people in the evaluation clinic, we find that has not sort of been quite up to date. A person who's maybe a couple years past 50 and hasn't had a colonoscopy yet, or someone who's a little behind on mammograms or getting their PSA checked or things like that. So all that routine healthcare stuff, we need to sort of sometimes catch people up as to things that may not have been done yet or they're a little behind in. And then the other aspect of it is there's additional testing that has to be done to make sure that the rest of your body is okay to tolerate the operation. It's typically a 3-hour surgery, but it can be quite stressful on the body. There's a lot of fluid given. You're under general anesthesia. There's other aspects of making sure that your heart, your blood vessels, and other things like that are okay so that you can tolerate that operation and enjoy the benefit of the transplant. And so that's why we have to put people through additional testing to make sure that they can tolerate the operation and do okay after a transplant. Number 3, find a living donor, as has already been pointed out, and this can be family, friend, neighbor, church member, coworker, former classmate. Those are all people that I've had the opportunity to do a living donor kidney from into a recipient in recent memory. In some of our younger patients, the importance of social media, and not so much these sort of websites that we were just referring to, but even just sharing their story on Facebook or other things like that that they may be on, sort of brings awareness to people that may know them through maybe not a day-to-day contact, but have known them in the past, to become engaged in what's going on with them. We recently had a nationwide campaign on Facebook to increase the number of people that would register as deceased donors. So if something were to happen to them, Facebook used a link to help people register within their state to become a deceased donor if they suffered some type of accident or other stroke or other event that would make them an eligible deceased donor. And in a similar manner, we're working with them to actually educate people about living donation, and there soon will be an app actually that people can look at and kind of track their status and things like that using the Facebook site. So one of my colleagues, Dr. Andy Cameron, is working with folks at Facebook to design this. And another important area that we believe is helpful is a program that we've had at Hopkins called the Donor Champion Program. And it's a difficult thing that we found sometimes for someone who needs a kidney transplant to ask someone else to donate a kidney to them. But oftentimes, that person has a spouse or a friend or another relative that is medically unable to donate a kidney to them, but can kind of be their liaison to tell other folks about their loved one's plight. So the ask or the sharing of information doesn't have to come directly from the patient, who might feel more self-conscious or find it a difficult task, but it can be, if I need a kidney, perhaps my wife isn't able to donate to me, but she can be the person that tells my friends or my family about my plight and perhaps stimulate interest in one of them to donate a kidney to me. And this is something that we're studying and continuing to study, but we've had sort of pilot programs in this and have seen some success with this program. The fourth item I just want to briefly talk about, because this could take the rest of the afternoon, but there's a new kidney allocation system. There are terms that you may have heard if you're already on a list or have been evaluated at a center that's part of the old system and the system that's still in place for the next 2 months, which is we called deceased donor kidneys in two categories: standard criteria donor, or that SCD, and also expanded criteria donor, or ECD. There's going to be a new system that's a little less two-tiered and more of a continuous scoring system from 0 to 100. It's called the KDPI scoring system, and basically it's a system where the lower the number, the better the kidney. And it will give us more shades of gray in order to be able to sort of score the deceased donor kidney offers that we get. The other aspect of it is recipients are going to be matched with donor kidneys based upon expected longevity. So an older patient who may have had diabetes for a long period of time that's caused their kidney disease will be getting offered kidneys that are higher up on the KDPI scoring system. This is all going into effect in early December, and that's sort of what's been approved and is in the process of making the programming changes for that to happen. A couple slides ago, I spoke about the importance of getting referred early. One thing that's going to change in this new system is pre-registration or time that you spent on dialysis before you go on the waiting list will now count. So if you get listed on January 1st of 2015 to go on the deceased donor waiting list, but you've been on dialysis for 3 years, you will effectively be treated as if you were listed 3 years ago. And so that gives patients that have been on dialysis for longer periods of time the advantage of having reaccumulated that time because they may not have been referred or sought out a transplant earlier in their kidney disease. You can still be listed before you're on dialysis as long as the GFR is less than 20, so that importance of early referral remains, but it's sort of two different paths now, or two different roads you can go on to gain time. And there will be a few other things that are maintained or changed. Some patients who had a prior transplant or a lot of transfusion or women that have had exposure through pregnancy can become sensitized, and that there will be priority given for sensitized patients in this new system, along with pediatric patients and a few other things. And our fifth point, and I apologize to Dr. Gilbert, Baltimore is the best place to be, in our opinion, if you have kidney problems. You have two programs here, Hopkins and Maryland, and I didn't know there'd be a program from Georgetown, so I apologize, but they're DC. DC is a good place to be too. But both have are probably the busiest kidney programs in the country. They have robust living donor programs. We import a lot of deceased donor kidneys from outside our area into Maryland, into the Baltimore OPO, to give them a second look. For example, right now, there is a kidney that came in from New York City, not Rochester or something, but from New York City that they sent down to us. My colleague at Maryland's putting it right now. I'm kind of angry that I didn't get it, but my patient was 2 people below his, so he's putting it in right now. It's a great kidney. It's going to go in. It's going to work. And their loss is our gain. And so we do a lot of importing of kidneys. Some of them are not used. About 50% are not used. But we take a look to see which ones can be used and try to use them. As a result, we have some of the shortest waiting times in the Northeast United States. It's one of the problematic areas to live. There are a lot of people with kidney disease, and the waiting times can be awfully long in other cities in the U.S. or on the West Coast. But in Baltimore, we have some of the shortest waiting times at Hopkins and at Maryland. And we have specialized programs for sensitized recipients as well, most of which involve living donors. But that's another additional advantage to being in the Baltimore area. And I will open it up to questions. I'm a surgeon, so if people have more surgical questions, I can try to address those.